Thank you very much. I hate slides because I'm constrained. And there are a few remarks that I'm going to start by making in a friendly way with what we're talking about. The first question I'd have, are standards the body of the dog or the tail of the dog? And I think that's becoming increasingly an important question. So do we take what standards that exist and we design a system, or do we design a system and look at what standards we need to use? And I think that's increasingly becoming a key point in what we're doing. I also would suggest that about, and I'm making these numbers up, but 80% of what we do is an attempt to get around a problem that we know, and we know a solution, but we spend all of our time and energy finding a way to get around it. And I think there's too much happening too fast now that we can afford to do that. And particularly, you know, I think IHE in the US and IHE in Europe are very, very different organizations. And I think, I must confess that IHE in Europe has done a much better job of working with the other standards body, particularly with HL7, and we haven't been quite as fortunate in the US. There's two projects that are called structured data capture, one of which is using IHE, one of which is using HL7, and we have a full working group whose total job is to map from one to the other. If we would just simply work together, we would have finished that particular project. But I am going to talk a little bit around some of the things that I think is very different. I've been involved in standards really since around 1981, so quite a bit of time with standards. And when we started HL7 in 1987 with version 2, the people that created the standards were the same people that were going to implement the standards, and they were the same people that were going to use the standards. We were designing hospital information systems by putting together a group of what we call niche vendors. Somebody did an ADT system, somebody did a lab, somebody did a pharmacy, and we wanted to be able to put them together without spending a fortune on the interfaces, and that was the beginning of HL7, a small group of people very focused on what they're doing. DICOM was the same way in the imaging. It took 6 major vendors, and they did a fantastic job of doing that. We've lost a little bit of that, I think, in what we're doing. But where we are now, the biggest thing I would say is that the world now are aware of the use of standards. More importantly, the world is aware of the need of data sharing, and data sharing in itself, I think, demands that we have standards. And so not only do we have developers, but we have different people than those that are developing the standards that are implementing the standards. So the EHR vendors, some of the niche vendors still are doing it, but they're not the people that directly are developing the standards. But a huge group now is beginning to appear on the scene looking at some of the people that Charles named in terms of citizens, in terms of all the different professions, but more importantly, all of the clinical specialties now are recognizing the fact that they want to do something with the data. They're recognizing the value of analytics. They're recognizing the value of aggregation of data across multiple sites, building registries, those types of things. And so the application users are now beginning to be involved and identified. And the difficult part of that is we don't all speak the same language. And so I think that's one of the challenges. We don't have the translators that are translating us and helping us here. But I sat in a session that I didn't even know the language necessarily. Maybe, I guess it's Greek, but it's certainly Greek to me. But I'm seeing the slides are in English, so I'm picking up at least half of what they're talking about. But when you start talking, the people that build the standards start talking to the users, they get lost completely. So one of the challenges is learning how to do that. The other things is standards have to be dynamic, and if you look at HL7 again as an example, in V2 we simply were trying to put together information to create a hospital information system by so-called best of breed. And then we introduced the data model, and we created version 3, which to me was a very complex standard. I think that its take-up has been very limited because of the complexity. So the technical people dominated that process of creating version 3 and didn't begin to bring the implementers into the scene for what they were doing. But the consequence of that was development of a data model and then a standard based on that data model. But then we brought another community in that created the CDA. And the CDA all of a sudden was something that at least the clinical people began to recognize what it was that we were sending. So they were seeing this controlled structure with XML tags in such a way that you could look at this, know what you're sending. The problem was it was very rigid and very constrained, and that's continued to evolve to FHIR, which I will talk about a little bit, not a great deal about that. But beyond FHIR now, at the same time, we're beginning to see mobile devices. And I would say that I'm wearing an Apple Watch that goes from my watch to my cell phone, to my electronic health record at Duke, to my personal care provider, who looks at it whenever she wants to look at it. So there's a little bit of scalability and a problem here. But I'm in Paris at the HL7 meeting. I get an email from my personal physician that says, your blood pressure is running lower than I want it to run, cut your meds in half. So I had a real world example of where somewhere in the world, something that I'm doing every day, not in the hospital, but she's observing that because of the fact that there is a wearable device that's sending data to her. Now there's some issues that we need to solve with that, one of which is she couldn't do 4,000 people, she could only do me. So that was okay with me, but those are the kind of things that I think we have to worry about too. So in the U.S., and I think these may be things that are knowledgeable. I don't know the extent at which Europe is doing all of these, but we now have, the president introduced something last year called precision medicine. And the idea behind precision medicine is that you as an individual have a set of characteristics, you have a course of a disease, you have a treatment that would work for you. And that's what we're trying to do with precision medicine, is learn enough knowledge so that we're able to treat you as an individual. And what we do for you goes well beyond simply clinical medicine. It looks at social and economic behavior. All of those other factors come into play with precision medicine. And then population health, again, changes our perspective. Much of my career has been focused on clinical, with a little bit coming in on research. Now it's beginning to focus on people and population and communities. And again, we have to learn how to work with the people that are involved in the communities. These are the governments, the city, state, county, people, churches, all sorts of organizations, schools. So that whole community comes together, and we need to learn how to talk with them and work with them. The cancer moonshot, again, it's the accumulation of data across multiple. We're trying to do something called pragmatic clinical trials. We try to do clinical trials out of data from electronic health record systems. And the problem we're encountering is that the data in the electronic health record system doesn't have sufficient quality, doesn't have sufficient consistency, doesn't have sufficient completeness to do the trials. The cost of a trial is maybe $50 using a pragmatic clinical trial. And if we are doing it as a randomized control trial, it may cost as much as $20,000 or $30,000 per patient. So this is huge in terms of our discovering new knowledge. And so we need to improve the quality of the electronic health record, and part of that is some of the standards that we need to create in the process of going there. Big data to knowledge is one of the ways that we're finding out about people. So big data is accumulating data. My goals are really to see the whole world connected together in some way. And then we look to see who looks like you and what happens to them 20 or 30 years from now. So that is the way that we recognize that the current disease labels that we use are really umbrellas. Something like type 2 diabetes, we've identified 8 different presentations of that disease by looking at big data, by looking at people over time, temporal phenotypes, if you will, and finding out what's happened to them too. And then learning health is a new magic word, but digital health, mHealth, and eHealth. And I think we're going to see next year the word digital health is probably going to become the dominant term that we're going to be using for everything that we are talking about. But FHIR was introduced, actually in 2011, I guess, 2011 was when it was first, the ideas started. And it's interesting because when we first started, we used the word draft standard for trial use. The word draft scared everybody because they said, well, I don't want to do anything that's a draft. I'm going to wait until it's finished. But the idea was that if we create a standard and somebody needs to try it to see if it works, it's a test to see if it is doing the correct things, if it's forgetting something, all of those sorts of things, we need to go through a period. So it's not a bad, it's a good kind of thing. But since the word draft was sufficiently scary, we dropped the word draft, and now it's just called a trial standard, a standard for trial use. But it's a positive, not a negative. Now the thing about FHIR is you can almost do anything you want to do with FHIR. That's the good news and that's the bad news. And Charles alluded to the fact that that control of tens of thousands or even hundreds of thousands apps, extensions to the FHIR standard, all of those are things that are extremely important. And it's going to depend on all of those stakeholders that I'm talking about being realistic, following a logical set of rules. We need to manage the creation of all of these profiles and resources, or otherwise we will not have interoperability. So I'm not going to tell you a lot about FHIR, just very quickly going to introduce some of the words that are part of FHIR. It's based on a set of modular components that are called resources. And these resources are connected to each other using URLs. They're units of exchange, known identity and behavior. But one of the things that we recognized early on is if your standard doesn't permit me to do what I want to do, I won't use your standard. I'll find another solution, or I'll take your standards and I'll change it, therefore defeating interoperability by changing the standards. And that was a problem with V2. With V2, we had problems of we had not identified the exchange of data that people wanted to use, and so we had to create the Z segment, and Z segments that you do anything you wanted to do, but unfortunately, the people receiving the Z segment had no idea what it was. And even when these were good ideas, they built them into HL7, people didn't go back and change out the Z segment and use the standard part of version 2. The same thing may be true with resources because we have something called extensions that let you do what you want to do, but hopefully we're going to register those extensions and we're going to manage those in such a way that when they become core, then that becomes the URL, the reference that you're going to use as part of the core material and not part of an extension. But it's going to require that degree of control and support for what we're doing. And then profiles are a way of solving some of the problems. I'll give you some examples of what I'm talking about. So as Charles indicated, FHIR is using a RESTful API, so we're modernized the standard. It's a bundle of resources and messages and documents. One of the questions I think is interesting is when you pass data, are you passing it as a document or are you passing it as a set of data elements? And what does the receiver do? Do you keep it as a document, as a component, as a folder, or do you take it apart and put it into the electronic health record and putting everything within its slot? And there's a lot of debate and discussion about this. And I'm one of the people that believe that a few things are kept as documents. Some other things, you take the document apart and put them in the right slot so that you're able to find those in what you're doing. The positives of resources, it's service-driven. One of the problems with the CDA and the CCD is that you've got to fill in all the blanks. And somebody says, I'll only send one piece of data. Why do I have to fill in all the other blanks to be able to do that? Because that's the way that it was structured. But with FHIR, you can absolutely constrain a resource and send only the parts that you want to send. So if I send an initial set of data to a receiver, and I send a subsequent set of data, I don't need to fill in all the blanks that I started with, but I can send only what is different, what is changed. So it becomes a lot more efficient and better controlled by having the ability of constraining the message itself. You can modify the components when the needs change, and you can get portability in the components by you can move program code within the data itself. So the general documentation, you can use XML, JSON, and I think JSON is becoming almost the syntax of choice. Be interesting to see how well that flows through the other groups. And then there are the resources that we're talking about. So the resources are small, logically discrete units of exchange of defined behavior, the smallest unit of transaction, known identity and location, and all exchangeable content is defined as a resource. So everything you're going to send is a resource. You can't see this and can't read this, but I'm not going to leave it there for the time. But these are the current resources. And you can see it's everything from general care provisions, medications, diagnostic, identification, conformance behavior. The interesting thing is the number of FHIR applications excuse me, that currently exist uses few as 4, 5, or 6 of these resources. You can do a great deal of that. So these are many, many pieces, but the small set of these is adequate for most of the observations that we're exchanging themselves. And then profiles is simply a packaging of resources to do a particular thing. And again, we have a little bit of a word problem because the HL7 profiles are slightly different in my understanding than IHE profiles. IHE is doing some of the profiles that are HL7 profiles, and they're doing the other kind of profiles. And both of these need to continue to exist because you're going from end to end, whereas these tend to be focused specifically in terms of HL7. So to define a particular application that needs to communicate based on resources and extensions, and this gives you a list of some of the things that have been implemented using profiles. So it just tells you what to send under what circumstances. The landscape is changing. Health over sick care. Patients play a significant role now in data reporting. The focus on behavioral, social, economic, and environmental in addition to clinical. In fact, there was a study from the Institute of Medicine in which clinical was one of the small percentages. Behavior was one of the most significant factors in determining the health index of people. And now all of a sudden we have the Internet of Things, we have wearable sensors, mobile devices, and we have Internet apps, and how these fit compared to a centralized EHR, I think is an interesting question. So we are beginning to populate registries with a lot of apps that do a specific thing. Nobody's beginning to integrate these together. And so we're seeing a lot of one-offs that is ultimately going to be confusing and create problems unless we're able to solve some of those things that we're talking about. One of the things that's getting a lot of publicity in the United States now is based on SMART. It's an acronym, but it provides the rules for the creation of apps, interfacing of apps with EHR, and it uses FHIR resources to find the data elements that are part of what SMART's doing. So this enables the vendors to create apps that seamlessly and securely run across multiple healthcare systems. So you can have an EHR vendor from Epic or Cerner or NextGen or Allscripts or any of those, and I don't know how many have subscribed to this, but at least all the top 10 EHR vendors have agreed that they would support this framework. So it defines a health data layer that builds on FHIR and resource definitions. It applies sets of profiles to express meds, problems, labs, and other clinical data, and patients, clinicians, and others draw on the library of apps to improve clinical care, research, and public health. This actually comes from the SMART web page. There are now 25 apps that are registered with SMART, which is at Boston's Children's Hospital. Apple also has a registry of apps, and I don't know what that count is now, but I think it's over a dozen apps that are there. Duke has contributed apps both to the Smart registry as well as to the Apple registry. And again, these are very specific. They're focused on a small component, and we need some way of being able to manage these and put them all together. This is an example of Smart on FHIR. Comes from Stan Huff, in which they have multiple vendors, and this number has grown in the health IT systems, but it's using clinical element models and FHIR data profiles, using a REST API. It's using OAuth for authentication and authorization. It's based on a service-oriented architecture, and we're using mHealth, multiple mobile devices to be able to move the data in, and you can see some of the applications that come out of that. So this is my last slide, and it really does give you, I think, an example of where we are and where we're going. So one of the ways that we need to talk to these stakeholders that I talk about is drawing pictures. And I used to take just a big sheet of white paper and try to talk to the clinicians and say, tell me what you do. And it says, we do this. And I says, well, how do you know to do that? So I'm able to begin to communicate with them. We reach a decision point. It says, well, I do one of these 3 tests. And I say, well, tell me which test you do, and how do you know which test to do? And that's really seeing some struggling. It says, well, I just do. But it's a way of communicating and getting a defined set of rules that we're able to do this. So domain analysis lets us understand the data elements that we need for doing this, and then this is built into a logical model. We're using SEMI, a group that's creating data models as part of HL7, a process that tests and approves those models. They go into a repository, and then from there we're creating the physical artifacts. These become the FHIR profiles. Again, of the repository, we're hoping the repository are going to be rich enough with keywords and access and identification so you can look easily to see if something already exists rather than reinventing it. And then we'll create the apps in support of this, and then conformance testing for doing all of this. So I think that we are going to see huge growth, very different, and ending up, it's a wonderful opportunity. We've been doing this for a lot of years, and some of the problems that we knew 30 or 40 years ago still exist today. I'm hoping that we be able to put the groups together and really a true merger of where it's not just being nice to each other. It's the fact that we do things as pieces of the puzzle that fit together, taking the best of all the SDOs and assign responsibilities. Trust is a key part of this. But I think, Charles, your remarks open the door for making that happen, and I would like to see this group strongly encourage the SDOs to move in that direction. Thank you very much.